Hello. If you're watching this, it's because you're a student who wants to learn more about MIE, which is mechanical insufflator exsufflator, or also known as mechanical cough assist or machine cough. But also this corresponds to my other topic, which relates to it, spinal cord injuries. So just giving you a little brief background, this is my patient here who has a trach. He has a C1, C2 Asia A fracture, and this is our cough assist machine here. So we're going to teach you a little bit about hyperinflation today, cough assist, and you'll learn a little bit more about spinal cord injuries. So when we look at spinal cord injury patients, we are the goal for the spinal cord injury patients in respiratory care is we want to do deep breathing cough, but now how we do it will vary. We look at the C1 to C5 fractures because C1, C2 will determine if they have any injuries in that area. C1, C2, that's the highest level, which is the worst because that means they're vent dependent. That means they have to eat and speak on the ventilator, and it's the most severe because damage to the spinal cord at any level has potential to remove communication to the rest of the body below that point. Although injuries can occur at this level, they are not very uncommon. So that's why most injuries we see like C4, C5, but the most frequent cause for C1 fractures is diving, followed by like vehicle accidents, then falls that impact the head. Also, in addition to the initial vertebrae injury, the interference at C1 or C2 can cause vertebral arteries to inflict neurological damage, leaving the brain without a vital source of blood. So with that being said, like I said, C1, C2, the patient would be ventilator dependent. C3 to C5, there's those spinal cord injury patients, we can expect the patient can be weaned. And then C3 is where the breathing vertebrae is. When you look also at the diaphragm, that's our primary muscle for inhalation. That's the C3 to C5. Intercostal muscles, that's a T1 to T6. So that's the intercostal muscles. Like I said, T1 is T6. That consists of the internal intercostals, which assist in exhalation, whereas the external intercostals assist in inhalation. Our abdominal muscles are the T6 to the T12, and that assist in coughing. Like I said, our patient is Asia A, so that means he has complete lack of motor and sensory function below the level of injury, including the anal area. And whereas grade B, which my patient won't have, that's like some station below the level of injury, including the anal sensation. So what I'm going to show you today is how to use this cough assist machine. First things first, you want to make sure you have protective gear for our patient. Since it's going to get pretty down and dirty, you want to make sure you have your gloves on. You want to have your face shield because there's going to be a lot of secretions coming up. We're hoping to, since he's a C1, C2 he's a C2 fracture Asia A, sorry. To make sure you have your O2 power source plugged in. And then this is, you want to make sure the MIE machine always have a HEPA filter attached to it, and tubing not too long but enough. And what I like to suggest is adding a 15 millimeter piece to it, and then adding a little bit length tubing to it. So you want to have this long tubing, 15 millimeter, and then you want to have this with another 15 millimeter. That way, if the patient has a lot of secretions coming up and it comes up, then you can change out this part only and throw it away, instead of having one long piece, and if that part gets dirty, you have to change it out every time. Also, you want to have an O2 bleed-in if you know that patient has history of vagueling, but just be aware that because you have O2 bleed-ins, that can also be a fire risk because of, if you think about it, the machine can sometimes spark electric hazards, and having O2 bleed-in, that sort of is a fire hazard. So just be aware of that. But if you know that patient has history of vagueling, you can always have an O2 bleed-in, so always have that ready. Or on your ventilator, which isn't here today, but you can use this, you want to just make sure you hyperoxygenate the patient beforehand. This is a Hamilton, by the way. So we're assuming that he has a trach, and then this is where the tubing is going to be attached to the ventilator, and then you're gonna start up your machine. Then you want to make sure you have an adequate, usually for spinal cord injuries, you want to have it at 40 and 50. But if it wasn't, you can always set it and hit settings. Go down, make sure you're on manual mode, by the way, and you go down and then you just make sure you're on inhalation 40 and exhalation 50. Usually starting is will be lower pressures and you'll work your way up, but for spinal cord injuries, since they have no function at all to cough and whatnot, you have to make sure you give them a little bit more pressure than usual. So why do we do this? Taking a very deep breath, hyperinflating helps keeps the lungs healthy and open. Deep breaths help make coughs stronger, and coughing is one of our body's best defenses against respiratory illnesses. So this MIE, mechanical insufflator exsufflator, helps both with hyperinflation and coughing, which is the best defense against illnesses that could lead to pneumonia. So what we're gonna do right now is we're gonna hit, since everything's modified, so you wanna make sure you block this piece first, and then you want to, so we're having it blocked, and you're gonna test it out. We're assuming that you blocked it, and you hit therapy to start it up, and you go turn it on. It's going up to 40 within 2 seconds, and then exhale, it's going to 50, which it's working. So like I said, you're gonna hyperoxygenate your patient or have an O2 bleed in. Then you're gonna hit your ventilator and hit standby, and then you're gonna pop your top off and then hook it up to the patient right here. Sorry for all the shaking, but you're gonna hook it up, and then you're gonna give them a couple breaths. Make sure you see chest rise, and then you're gonna start it up. So to start it up, you want to make sure your suction's all ready. We're assuming that we have suction attached to the wall, and we're gonna start it up by counting to, and let them know, by the way, if this is not your patient's first time doing it, then let them know what you're doing every time. Explain to them why you're doing this. It's just like I said, before every treatment, let your patient know what you're doing so they know, because sometimes patients can get very have a bad anxiety, and especially being new injury in their spinal cord, it could be very, very, very hard for them. So let them know. We're gonna start it up by counting and giving them that breath. By the way, usually you wouldn't have this much time waiting for them, so you want to give them a couple breaths, like I said, and you're gonna start it up. So you're gonna do in, 2, 3, out, 2, 3, in, 2, 3, out, 2, 3, and then when you give them that breath, you make sure you have your suction ready and have it at the tip of the trach, and then you're gonna do in, 2, 3, and you're gonna flip to cough, and while that happens, you're gonna hit your suction, and hit the exhale. Cough, 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 cough. And then usually secretions would come up to the trach. Like I said, you're gonna be suctioning. You should be getting a lot of copious amounts back. So you're gonna hit the exhale and hold the suction at the same time. Make sure you give them intermittent breaths. Give them time to rest, catch their breath, and you're gonna repeat this. You wanna make sure, you can also combine this, by the way, with manual cough assist, quad coughing, if it helps them more. But like I said, you're gonna do in, 2, 3, out, 2, 3, in, 2, 3, out, 2, 3, in, 2, 3, and flip over to cough, 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 and out, 2, 3. It's very important that you suction while you're doing that, because if not, then it's just gonna come up all the way and it can clog up your tubing. Watch the patient, make sure they look fine, look at their sats, look at their heart rate, make sure they're okay, and then give them time to rest, because sometimes it could be very hard for them to adjust to this. And like I said, give them intermittent breaths in between, and you start up again. You're going to repeat it until secretions pretty much are lessened or there's no more secretions left. Usually spinal cord injury patients yeah, the resting pretty much. You can. Sorry, I'm losing my train of thought. So with this as well, the cough machine, like I said, is made up of inhalation time, which you're using positive pressure, and exhalation time. So when you switch to exhale, you're using negative pressure to draw up that secretions up. Between each sequence for rest, you should have at least 20 to 30 seconds and give them that breath in between, like I mentioned, and then use that time if you need to go down the ET tube, or the tracheostomy tube. If you need to advance your suction down just to get the remaining, you can always go down. And just a little FYI, if you ever stuck on this, make sure you twist the suction and then thread it. And then you can go down and then suction all the way out. Um, oops. My patient got disconnected. Ignore. But anyways, so yeah, that's pretty much